Welcome to the DNA Talks podcast, where we take on the mission of unlocking the code of your genetics. This season is all about you, upgrading your health, not just on the surface, but down to the root cause. Join us as your clinicians at the DNA company investigate your DNA and beyond. The intention of this podcast is to enhance your lifestyle by changing what is in your control. This does not substitute the medical advice given by your personal doctor, therapist, and other healthcare professionals.
Bonjour, bonjour. Hello, everyone. It is a delight and a pleasure to have you with us. And I bring forward very exciting subject matter and very exciting panelists. Before we jump into what we're talking about this evening, being endometriosis and PCOS, and what are we going to do about those sorts of things, I also want to take this opportunity to introduce a new panelist with us this evening. You'd almost think this was planned, but I'm very grateful that she's joining us for this conversation because I think her perspective and her approach, both to healthcare and then separately to hormones, it really diversifies how we're looking at this and really well rounds us out. So without many more words, I'd like to introduce Dr. Tracy Steady-Hardcastle to us and give her a little moment to introduce herself and how she fits into the DNA company and the sort of medicine that she practices. Tracy, welcome.
Thank you so much. So one of the things that I say a lot at the DNA company is that I feel like Chinese medicine was doing a similar thing. So it was taking people's constitutional chi, their energy, and their environment, their lifestyle, everything that goes into it, their illnesses, all of that stuff, and how those two things interacted. And that's sort of epigenetics, right? It's like what you come in with and what you put on top of it. And so, but my way is just a little bit, uses different words in looking at it and has some sometimes different approaches to dealing with things, but it's really similar. And so I think it all fits really well together.
Yeah. Yeah, I would offer in particular a lot of my training with both Dr. Mansour and then a doctor who used to work here with Dr. Winnie Su, who is very well steeped within traditional Chinese medicine. They used to often comment that genetics is simply saying what TCM does, but in different words. Right. And so once you learn the similarities of the words, you can understand the flow between the two. They were just capturing genetic pictures before we had genes to express it as such. Yeah. So why don't we start diving into tonight's topic? And it comes at a beautiful time because I think historically, but more of recency, there's a lot of concerns around women's health and how we go about addressing it. So from a history perspective, we're going to be talking about two conditions, which if you have never heard anything about them before, they couldn't be more on opposite sides of the spectrum as to how they present and what causes them. And yet, quite literally, if you go into a majority of GPs' offices, the prescription for these very opposite conditions is exactly the same. And Dr. Maria, I think your mic's off, but I heard her kind of emphatically being like, exactly. So we want to start discussing both to the end of what exactly are these conditions, but also to the end of ensuring intelligent, careful, informed conversation and access that women have to healthcare is maintained. And that's something that we will be doing within these webinars, within the DNA company mandate and the care that we're offering people. So on that note, ladies, why don't we start jumping in by discussing what exactly are these two conditions, and arbitrarily, based on the alphabet, going to pick endometriosis. Would someone, for the audience sake, like to just discuss what exactly that is, especially from that patient experience? What's happening if someone comes in with, hey, maybe I might have endometriosis. What are they feeling? What are they seeing?
So endometriosis, so inside your uterine tissue, right? Your endometrial tissue is the tissue inside, and it's the tissue that brings blood supply and prepares the uterine lining for implantation for the egg. And so when you have endometriosis, what you have is a increased vascularity, so more blood vessels, more support going to it. And you also have endometrial tissue that has gone outside of its normal bounds. So endometrial tissue can also be attached to other tissues. So the bowels, the ovaries, the fallopian tubes, and it's microscopic. So it's not something you can visualize just on a sonogram. But what makes it problematic is when your hormones shift over the course of your month and your estrogen levels climb, that endometrial tissue's job is to bring blood supply. So it's also going to cause pain and bloating and lots of other symptoms on top of that. And it leads to infertility and other issues as well. And I'm sure other people can jump in, but that's kind of my simplified form of what endometriosis is. And then there's also adenomyosis, which is a cousin to it, more painful, more problematic, more infertility issues.
Yeah. I'm glad you brought that up, because I think that's the proverbial redheaded stepchild that no one thinks to discuss, but is very, very important to the family.
Yes, very much so.
Yeah. No. Does anyone else have anything they'd like to add to kind of that commentary? I think, I guess, more the human side of it. I know several people with either undiagnosed or diagnosed endometriosis, and we'll speak to the complication of getting to the point of diagnosis, but many who have a working diagnosis of endometriosis, and their experience of life is much more trying when they plan their life around when they expect their period, their menstruation, because quite plainly, they will expect to be in bed for several days. Not only from the physical kind of, there's a lot of blood coming out and it's difficult to navigate the world because of that, but separate to that, simply the pain picture. So oftentimes people coming to see us, that's the first comment. My life revolves around my period. It is profoundly painful.
It could be very, very debilitating.
Yeah, absolutely.
If I can, mention,
Please.
getting into the genetic part of it, when you are talking about the pain, sensitivity, fatigue of endometriosis, in our reports, there are actually some genes that can impact or give insight onto that. For example, like the MAO gene. Okay. If you've got slow activity leading to altered neurotransmitter breakdown and, with the COMP, that could impact pain perception and emotional resilience that can influence that pain sensitivity, fatigue, which are often common in endometriosis. So these are aspects that you can look into your reports and kind of see. It certainly isn't going to change the fact, knowing that, going, yeah, I'm in a lot of pain each month, but it can say, hey, in your genetics, this is an area that you're a little bit weaker. What can we do to help support these particular pathways to help alleviate some of those symptoms? And then there's also the fact of the inflammatory response and detox pathways. When you consider that, say, the presence of the GSTP1 gene. So we're talking about the glutathione conjugation pathway. Okay. If you're suboptimal in that, maybe over aggressive in the GSTM1, and you have no copies of your GSTT1, that could affect the body's ability to clear these inflammatory environmental toxins, because these pathways are very essential in managing inflammation, very critical for endometriosis symptoms, and that condition that is inflammation driven.
Mm-hmm.
So,
yeah. I love that you're so beautifully touching on the idea of when you approach treatment for this. Typically it's, let's address hormones, but there's so many other avenues that, as a practitioner, when you work with someone, that are considered, right? It's not just a hormonal picture. Yeah. And I think TCM in particular is so wonderful in summarizing that, right? Because you guys look not only at the hormonal side of things, but the impact outside of that.
Yes, it's holistic. And considering how long, I don't want to jump the gun, but how long it can take to get a diagnosis of endometriosis.
Yeah.
I think the average is like 7 to 12 years or something like that.
Mm-hmm.
It's just complicated and difficult. And frustration of patients who would come in and be like, I keep going to the doctor and they keep saying, it's normal to have a painful period. You just have a more painful period than other people, and things like that, and just not feel heard in that was very challenging emotionally. And so, going back to Dr. Varden's point, if you have some of these other things going on in terms of your genetics, it can make that experience even worse of not feeling heard. And the autoimmune component to this and just the overall inflammation, I think it's not just it doesn't feel like just a gynecological problem. It feels systemic, both in terms of life, like the amount of room that it takes up in someone's life, to speak to Dr. Kostroman's point, and also that in terms of the body. So
Yeah. Yeah. So why don't we give a little bit of voice then to the typical pathway of, if you have endometriosis, right? What is the typical pathway that people are taking from that first presentation of painful period to the point where you actually go to a doctor and you say, "Hey, I think something's up." Right. And there's the ideal path, right? Where you're quickly ushered off for a biopsy and you're diagnosed, and then we know what to do. But let's be also honest about the typical path, because I don't ever want to set women up for the failure of expecting that they'll get the ideal path. why don't we talk about the typical pathway to diagnosis here and how that's done?
I think so many women, they end up going, or women and young girls, let's face it, this starts as soon as you start menstruating, that, most of the time you present with pain, you go to the gynecologist. If you have a regular pap smear or even a sonogram, I think that's the biggest thing, is the regular office procedures that someone could do to take a visual of some of those organs cannot see it. And so it really requires a procedure, a biopsy, which is pretty invasive. So I think this is just me extrapolating, but I think a lot of young girls and women struggle and go through a lot of pain and suffering because of that, right? So women often don't even get diagnosed until it might affect their fertility. So there is this sort of battle. I think it's also understanding we don't have good blood markers. We don't have ways to check it in a very passive sort of way.
Yeah. 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 I also hear commonly too that it's, to a degree, the doctor almost saying, "Hey, I don't know if we need to biopsy you." And their logic is, if we confirm this is endometriosis, I'm not sure it's going to change how I treat you. Like, having a formal diagnosis versus not. We already know you have these symptoms. Here's your oral contraceptive pill. Come back in 6 months and let me know you're doing better. There's an element of doctors, to a certain extent, they're like, "I don't know what to do even if this is confirmed. So I don't know if I want to put you through that effort, or I don't know if I want a requisition for that effort." We won't assume their mind. But there's an element of just difficulty getting to diagnosis, because so what once you do have it, right?
Yeah. I mean, I think that just sums up a lot of what we just see in medicine, and particularly women's medicine, is, the cookbook, the flow chart that was created based on, really kind of overlooking women, goes A plus B equals C. If we don't have anything to do with C, they just go, "Oh, forget B. We don't even need to look at it. We're just kind of skip over that because we don't know what to do with it." So you're right, because the only thing you really can do from a surgical standpoint in the conventional medicine mind is to scrape it off and remove it, right? Or have a hysterectomy. But, that's the next sort of leap, I would say. I wouldn't say that's the right answer, but that's where the conventional leap goes. Would you kind of agree?
By and large, yeah, it's at least the cases that I've seen, there's been incredible intervention of, here's the pill plus a lot of pain management. And unless you want a hysterectomy, you kind of have to suck it up and deal with it. And Dr. Varden's already alluded to this. There's much more than just sucking it up. We don't want you to make you feel like this is a suck it up conversation. We just want to be very honest about the lay of the land. And so I wonder if we pivot a little bit and define what PCOS is. And spoiler alert, audience, the prescription of a pain pill, the oral contraceptive pill, is exactly the same here, even though this condition is going to be starkly different. Who would like to offer up to our audience the definition of PCOS?
it stands for polycystic ovarian syndrome. And syndromes are so TCM because everything's a syndrome. A headache, there are 12 different kinds of headaches. And so there's some fairly specific criteria, although now there are 4 phenotypes, which is definitely also more like in the TCM thing. But typically people have irregular or anovulatory cycles, meaning you don't ovulate and your cycles can be irregular. On an ultrasound, you can see multiple cysts on the ovaries, and that's where the term polycystic comes from. And also hyperandrogenism, meaning you have more androgynous hormones, more testosterone in your system. And so you can have symptoms of that, like maybe hair in places that you don't want it to be and things like that. But there's also this metabolic component that isn't even addressed in the name. And there is a movement to actually change the name of this because it's more than just having multiple cysts in your ovaries. It's like a whole big, once again, it's a systemic thing and multiple factors that need to be addressed at once. So I'll let someone else pick it up from there.
I love that you have a happy relationship with syndrome, because I think your medicine was styled intelligently around that. Whereas typically, by and large, within Western medicine, if you hear anything as syndrome, it means you have a bunch of symptoms. We don't know what to do with it. So we're going to toss it in this bucket and hope that we can figure it out later. And so syndrome, I think, to Dr. Steady's point, she just said there's 4 different subclassifications of PCOS, meaning what we once all lumped together, we're now learning can be broken down differently. And so we're getting more discerning within the bucket of PCOS, within our alphabet soup, where you might fit, right? And so this, to an extent, will lend to, and I wonder maybe if Dr. Varden or Dr. Murray wants to speak to this, many different presentations of people who show up with PCOS. I think the typical thought was it was going to be an overweight woman with a lot of acne, and that's not always the case. Sometimes, absolutely, but it's not always the case. Like, what does the person look like who shows up with concerns of PCOS or that ultimate diagnosis?
Yeah, I think first off, the assumption that it was always this dominant sort of, it happens when somebody's overweight, and it's actually I think one of the things is you've got one of the phenotypes of PCOS is definitely excess body weight, but it's usually a smaller upper body and more what I like to call junk in the trunk for those of us that have a little extra, right? We have a little booty on us, right? So sometimes we can't, because Go ahead. Right. That's right. Well, and it's because it's how the hormones impact where fat storage is stored. And so one of those phenotypes is very much driven by insulin receptor activity and the lack of sensitivity. And it affects ovarian function and sort of increases the androgen side and affects estrogen. And so therefore, when girls go into cycling, when they start menstruation is where we often see it. And so that was always the classic mindset. But there's other phenotypes that don't really fit that classic situation. And we have what we call the very stereotypical and a kind of very thin PCOS as well, that doesn't fit that insulin resistance sort of pathway activity. And, personally, I look at that and say, well, that means we have a ton to look at, right? Because we don't obviously understand it as much, for sure.
And I wanted to throw out the fact, and I'm going to be transparent here for revealing information about myself, but also, when you're looking at your reports and say your hormone profile is one of estrogen dominance, that doesn't mean that you could not be diagnosed with PCOS, which is more related, like what Dr. Betty was saying, more of that androgen dominant, because I am estrogen dominant in my hormone profile. But yet when I was younger, having children and everything else, I was actually diagnosed with PCOS. And, I, was in good shape. I didn't actually, gain weight and have the issues that I had physically until after the car accident, which was after I was 30 years old. But I mean, I had been diagnosed and stuff like that in my mid to late 20s. I mean, I was like a size 4, 6, professional figure skater, running, very active and everything else. And it's like, exactly the thought of large breasts, just not your typical, but yet, yes, I was diagnosed with that, as well as with hirsutism, which is that awful, hair in places you don't want them, namely like, chin, neck, the jawline area. And then oftentimes it will have like a darkened skin area around the neck. That's another sign for hirsutism. Also with some thinning of the hair. Well, granted, thinning, but I think that's more from stress and all the surgeries and everything else I had. But even still, your hormones are so nuanced and they are so delicate in such a way that it's almost like a teeter-totter, that it's on a very narrow spot. Like anything, almost could turn it either way, no matter what genetic profile you happen to have. But it is still, good to know what your profile is. Do you convert progesterone to testosterone faster? Like I do. That's why I have a dominant profile, and that's through your CYP17A1 gene. But getting into what Dr. Tracy was talking about with the metabolic aspect, to be aware of, your markers for insulin and insulin resistance, the TCF7L2 gene. This can be very important. Also looking at the other genes that are relative to that, your AME1, some of your other fat metabolism, the FTO gene, and how this works and how it can affect insulin. Because I also was diagnosed pre-diabetic, was put on metformin, and all these other things. Now, granted, I have shifted out of that and no longer have that diagnosis. I'm not on any of the medications, but it's still a reality that you can deal with these things, but you can also, through knowledge, through the basis of knowing what you have to work with your genetics, and working with someone who knows who can help move you out of that state, or at least alleviate those symptoms. So
Yeah.
And I think there's also acknowledging that it's also either a lack of progesterone or a lack of progesterone receptor activity and sensitivity, that is also part of it. So somebody could be estrogen dominant, obviously on their genetic profile, still have high androgens and relatively high estrogen and relative low progesterone, and that is one of those other sort of phenotypical experiences as well.
Yeah. I love that what we're touching on right now is really the importance of lab work, your genes, whatever that might be, but coupled with the insight of a clinician and that third party that is able to, with care, stitch it all together, right? Truly, because there's complexity to endometriosis. There's a lot of complexity to PCOS, given it's a syndrome. Right. And the power there is sitting with a doctor and truly understanding what exactly is driving yours so that you can tailor the solution outside of just here's a pill to that end. Yeah. Oh, I love that. Dr. Varden, Dr. Murray, Dr. Steady, thank you so much for kind of very beautifully articulating that.
Can I say one more thing?
Yes, please.
They just redid some of the guidelines for treatment for PCOS in 2023.
Ooh.
And a lot of it, wonderfully, had to do with lifestyle and bringing in more of a multidisciplinary sort of team to manage it in different ways. And I also guess I just wanted to put in kind of a plug for herbs.
Yes.
Some of them can bring down LH and FSH. Some of them can prevent a testosterone from converting to DHT. Like, there are just a lot of these things, to put it in, I would say it in a different way ordinarily. But I also am fluent in this because I have to be. So there can be more subtle treatments than a birth control pill. There are plenty of nutraceuticals and plenty of herbs that can also be used to help manage this in addition to lifestyle things. So there are other options out there.
Ladies, would you agree with the statement of, I've heard more reversal cases of PCOS per se than endometriosis, insofar as if you understand what can be driving your PCOS and you're not kind of one of those more severe, significant cases, oftentimes I see a lot of women being able, like Dr. Varden, to reverse it to a certain extent where it's something in the back of the mind. We're like, okay, cool. I need to keep my lifestyle in check so this doesn't come back. But it's something that can be reversed and then very well managed insofar as it's not part of day-to-day living. I'm seeing some nodding heads. So I'm seeing agreement there. I haven't seen that as often with endo because I think there's a lot more to that. But with PCOS, especially given it's that huge spectrum where so many people can be included, there's a lot more instances of reversal. And that's really where a good care practitioner. Any disagreement?
Yeah. I was thinking about the endometriosis. I think the challenge is by the time the symptoms present, you have tissue in the wrong house, right? Like your tissue escaped your uterine house and is now hanging out in your neighbor bowel house. And that's the challenge because really you can't get it to creep back into the right house anymore. right? And so it almost always has to be surgical intervention to, at least if the goal is to get it off the tissues. And so to some degree, there becomes a management, and we definitely do this. We look at it as, okay, let's do everything we can to support those hormone pathways to reduce all of the risk factors that are modifiable, so we don't get it, because it can grow back, just like vines that you cut off the side of your house, and the next summer they climb all over it again. You're like, okay. So I think part of it is almost, there's a part that we don't have visibility to until it's already present at a way that's so symptomatic.
Yeah. Very good qualifier there. Thank you. All right. Why don't we get a little bit more specific? Why don't we get more specific as to, and maybe Dr. Steady, you kick us off a little bit insofar as how do we start approaching these cases? What considerations can we have? Because I think we've tossed out herbs, we've tossed out lifestyle, we've tossed out medication and surgery. So let's park surgery for a little while, and why don't we dwell a little bit more on kind of the non-surgical, more accessible to a certain extent options. So when someone presents with you, they're diagnosed or they're on that course 2B of either endo or PCOS, with appreciation, they're very diametrically opposed. What are the first things that you're thinking through, Dr. Steady?
That is tricky because I'd be thinking through different things for each of the conditions. So the most important thing to me is always what's bothering them the most. So I would be asking what their biggest symptom is. And for endometriosis, a lot of times it's pain or it's infertility. Those are the two main things that those would be their chief complaints, for lack of a better term. And I would actually go about things differently depending on whether it was for fertility or whether it's for pain. Because if it's for pain, you can use herbs that you can't use if someone's trying to get pregnant. So that's why always make sure you know the goal of the patient before trying to figure anything else out. But one thing that I will say that has been shown to help with pain is regular movement. Even though, so from a Chinese perspective, stagnation creates pain. Where there's blockage, there's pain. Where there's pain, there's blockage. So that's just sort of one of those Chinese medicine sayings. And exercise in studies has been shown to help people with their pain management in endometriosis, even though the last thing that someone probably wants to do. I'm not saying that someone would have to do that on the worst day of their cycle or anything, but all of the other days, that is something that will help. And then now I would definitely be looking at their genetics and also trying to keep their inflammation down, being careful about what they're eating for inflammation, stress, going over some meditation, breathing techniques, things like that. For PCOS, it would depend what their symptoms were once again, but, really trying to manage the blood sugar piece and once again, looking at their genetics and trying to figure out, what their hormone picture is. What is there too much of? What is there too little of? Those are the kind of the two baskets that the Chinese medicine puts things into. And it's really not that dissimilar. Are you estrogen dominant and you don't have enough progesterone? It's sort of the same thing. So just trying to balance all of that out with supplements and herbs. And once again, stress management. And there can be a lot of, depending on the presentation of someone's PCOS, there can also be this sort of body, I don't want to say shame, but people are self-conscious sometimes about their symptoms that they don't feel like they can control. And so really also keeping an eye out for the emotional impact that all of this has on them. Infertility is really hard. Not wanting, being worried that a whisker is going to show can be really hard. And depending on the age that's happening, it can be, for someone who's in high school or something like that, that can be a really, really big deal. And I'm not saying it's not a big deal if you're in your 20s or 30s, but I think the teenage years are very tender and I feel very protective of that age group. So that's all that I can say for right now.
Oh, I love that. And thank you for raising that, because I think within conventional medicine in particular, that consideration of what is your experience in the world with this condition isn't always there. And it is usually the biggest driver to getting someone into clinic.
And I got to say that hair on the chin, even when you're 50, really sucks.
Yes, it does. Because the rule is, if you can see it from the sunlight in the rear view mirror, it's a real thing. And I never had hair. I was not hairy before, but dang if I'm not now. It's interesting. I want to say a couple of things on that. I want to say too that I think we have a very cursory understanding of polycystic ovarian syndrome and the complexity of it. because there are a lot of women out there who exhibit a whole lot of the symptoms. But the one thing they are not having is they are not having complete lack of periods or very, very distant periods. Because the reality is you could be having a period and be anovulatory, right? So you could be having a period and not actually shoot an egg out of your egg carton, for everybody, which is what anovulatory means. And it happens when we're in perimenopause, into menopause. But I think a lot of women and girls are getting overlooked or being told it's something else that really are having that, but they're not ovulating, right? But they're having the joy of the period just because we want to always have that. But I think there's that. And then there's also women that when you get to your 40s and, and progesterone levels are on their natural decline, right? You end up in an estrogen dominant state anyway. You can get polycystic ovaries at that time because the other hormones are out of balance. And then you go, have I had this all this time? And I don't know, potentially.
I love that very beautiful, graceful admission that the course and the nature of this changes with time. It's not something, if you had it in your 20s, you can't get it when you're in your 40s. Yeah. Yeah, I love that. Thank you. I'm curious again, I want to shift to Dr. Varden in just a second to kind of understand maybe genes that she's considering when she sees someone with either condition and is trying to form up a clinical plan there. So Dr. Varden, someone presents, Dr. Steady offered endo first and then PCOS, but for those conditions when someone comes in, what genes are you considering? So obviously their hormone profile.
Oh, absolutely. And again, to reiterate what Dr. Tracy was saying, you got to know what their complaints are, what are going on, what's going on with them, and then looking at their genes. So let me start with PCOS and like some of the symptomology and things that I would look at. So I would look at their androgen conversion. So genes related to testosterone and androgen conversion, these are your CYP17A1. So I'd be looking to see if there's a G allele, a faster conversion to testosterone. Another one, the SRD5A2. If there's a G allele, it's a faster conversion to DHT, dihydrotestosterone, which is 3 to 5 times more potent than testosterone itself. We as women don't really want that to be very fast, but there are some benefits of it, but when it comes to PCOS, that faster conversion can lead to that type of presentation, because again, these all are linked to higher androgen levels, as well as their clearance, the glucuronidation pathway. So these are the UGT genes and the CYP3A4. How fast are they clearing testosterone? Because if they're not clearing it very fast, then there is this reservoir of testosterone concentration that just kind of keeps building. Really, it's looking at all of the pathways. Also, how well are they binding to the androgen receptor? That can play a bit of a factor in there. But those definitely the main ones. They contribute to those PCOS symptoms like acne, hair growth, hair loss. Also, I would look at their estrogen conversions, the CYP19A1 gene, the aromatase gene, because if they're a carrier of a slower allele, the C allele, that can lead to less estrogen conversion. Again, also, higher androgen amounts. This can exacerbate the hormonal imbalance, potentially influencing that ovarian cyst formation and the menstrual irregularities. Then, because we don't want to forget about this, as this really is super important that Dr. Steady had mentioned, the insulin aspect. So looking at any insulin resistance, obesity risk, and I had mentioned this earlier. So the FTO gene, fat mass and obesity gene, okay, the TCF7L2 linked to your insulin response, that can contribute to that insulin resistance, weight gain, and PCOS. And I also mentioned about AMY1. Okay, involved in starch metabolism that can affect weight gain if there's any decreased metabolic response to starches. Also looking at the ApoA2. There's just this plethora of things that really make a difference. I know it's kind of like, oh, let's go through the whole thing. But they do impact in in certain
Yeah.
ways.
Yeah. Yeah. No, I love this. So I wonder if there's anything else to add, Dr. Murray. I'm looking at you in particular because I value the number of women that your clinic supports here in this space and the clinical pearls that I know you just kind of have oozing out of all the goodness of you.
You could feel it. I had something to say, right? So particularly endometriosis, I would say we know a little bit more about this. So your estrogen clearance pathways, so your CYP1A1 and 1B1, if I have a slow slow A1 and the 1B1 is mutated, right, where I'm making more hydroxyestrone, particularly the 4-hydroxyestrone, those are associated, higher amount of 4-hydroxyestrone, lower amount of 2-hydroxy with endometriosis. Right? Because you think about it, and it makes complete sense. The estrogen burden is going to be higher. And then if we add toxicities and things like that, we just have a higher likelihood for that. The other thing that I think is really also undervalued is the COMT Val-Met 158. That one also bit of an indication because again, you're sort of marching estrogen to the exit door, but along the way, it's getting slowed down and impaired. And then downstream from that, how they actually get out of the body. So, those are things. And I think when you can marry those kinds of results with hormone metabolism, urinary testing, like the Dutch test or the HUMAP, and even things like organic acids, where you actually see these genes in action, that starts to help you marry the genes with what's really occurring at that time. So you get a really clear picture of what's really happening now.
I love that. So part of your intake, part of your ethos very much is appreciate the patient, then do a lot of testing, especially to monitor as treatment is coming along.
Yeah, because I think it's really important too to understand, to Dr. Tracy's comment, is it's the epigenetics that really drive what's happening. The genes inform where you're probably going to go, right? But you got to turn that, you can turn it up or you can turn it down. And when you add those tests, whether it's urinary hormones, OAT tests, or even blood, some blood tests, that starts to give you an understanding of what's getting turned up, and so, there might be cases, let's say, of an MTHFR SNP, but you're eating in such a way and getting the nutrients in such a way that it's not really being expressed. So you don't need to do some high dose methylated folate. Right. And I think that's where a lot of things get lost in the translation. Is I think it's always valuable to sort of pair those pieces together, because then you're really getting into the nitty-gritty of fixing your biochemistry.
Yeah. Yeah. I like the idea too, especially of those like treating and then seeing the person through lab values as well as in like through visit. I think that's very important too, because interestingly, I think I love that you mentioned COMT, right? So COMT really looks at methylation, how we go about clearing our estrogens. And so I think a lot of people will hear, hey, if I modify COMT, it's going to help with my estrogen. And they'll do that almost to excess, right? To the extent of it will help with their estrogen clearance, but then they come up more depressed, may not be the word, but almost just struggling with emotions, because that shifts how the brain processes things. Right. And so really being emphatic here around the consistency of care and access to care and working with someone like any one of these beautiful women on our panel today, who's very passionate around not only understanding exactly what it is, but separate to that, being consistent and present in that follow-up, because we don't want you veering off one way or the other.
Yeah, because more isn't always necessarily better. It's not how the body was designed. I love TCM for that reason, and Ayurvedic medicine both. It's like there's seasons and there's times and there's things and there's always like homeostasis and balance, and that's what we're going for. We're not going for the extreme.
Yeah.
Well, and I love living in a day where we have access to testing so that we can see how things bear out. And so when I see someone and I have their genetics and I have their Dutch test, sometimes it's like, okay, this Dutch test makes total sense based on their genetics. And then sometimes I'm like, that I would not have thought this was the same person. This is fascinating. What's happening here? And that's also a fun puzzle, but but that speaks to very much what they're doing is altering what the how the blueprint plays out in real life, right?
Yeah.
Or what they're being exposed to that they may not even know they are exposed to, like all of the endocrine disruptors, the estrogen mimetics, BPA, register receipts, all of these chemicals that are in our food, soil, water, air. I mean, it's just, we are inundated. And, that's why detoxification and supporting your detox pathways are so important.
Yeah. Yeah. I'm always shocked every time a new headline comes out that says like, hey, here's a way that you're poisoning yourself. Like the receipts, I've heard that. And it just, oh yeah. All the women on this panel, I'm sure, could go down this rabbit hole for hours. It's important. Environmental medicine is important because it is shifting the presentation of these concerns, right? Our first question speaks to infertility. And I think historically that was something, maybe we started addressing in the 30s and starting to see those concerns come as early as mid to late 20s now.
An excellent conversation, ladies. Dr. Steady, welcome to the panel group and being a part of this conversation. You were amazing. So thank you for that. To speak to what you just said, we will continue to support women at all junctures of their life and find ways to continue to improve upon testing and access and education and information. And we have people like Dr. Murray here, who is an industry thought leader, 1,000%. And we definitely will continue to do all of these things. So I just wanted to say thank you to all of you. This is an important conversation, and we're going to continue to have it.
Yeah. I think if you've heard the variety of opinions just on this panel, but our goal is not to tell you what to do. Our goal is to tell you what options you have and then supporting you in whatever choice it is to whatever option you want. You're in the driver's seat. Our job is to educate and then facilitate, nothing else. So on that end, ladies, thank you so very much. It's such a timely, well-nuanced conversation that we had. I learned stuff, and I love when I get to come into these webinars and say I learned something. So ladies, thank you so very much for offering your brains and your hearts to this. We really appreciate it. To our audience out there, thank you for coming. Thank you to all the advocates of your own health or of people that you care about health or just your general advocation. We love it. Thank you. Please stay tuned and we will see you later on. We can all dance out so that we can be happy in spite of everything that's going on. Au revoir, mes amis.